of Shadra, New Delhi. He is educated till 10th standard and owns a garment shop. He was examined on the 8th of September 2021. Informant is self and the history seems reliable. So presenting complaints, he's a known case of chronic kidney disease stage 5 on maintenance hemodialysis, twice weekly maintenance hemodialysis since 2014, and has presented for routine hemodialysis session. Sir, history of present illness. Sir, the history of my patient, it starts around 7 years back in January 2014. He was in usual state of health back then when he started developing recurrent bouts of headache, which were acute in onset, holocranial, throbbing in nature. They lasted a few hours and were initially relieved by single analgesics. They were not associated with any nausea, vomiting, or any blurred visions to start with. He also started developing an insidious onset reduction in appetite associated with
अभिषेक,
these headaches.
सॉरी, तुम्हारी स्लाइड्स क्या तुम दिखा पा रहे हो?
So slides nahi hai, sir. I'm
अच्छा, ओके,
only reading out.
डजंट मैटर.
Only reading out.
ओके,
Sir.
परफेक्ट, कोई बात. गो अहेड.
Sir. Over the next 2 months, he developed progressive breathlessness on exertion, which was initially grade 2 and progressed to grade 3 over a period of 1 month. However, this was not associated with any chest pain, any palpitations, orthopnea, or any swelling over feet. One day, the patient developed had a severe bout of headache, which was intractable, not relieved by his usual analgesic, and had an episode of vomiting along with increase in breathlessness. He was reviewed for the above mentioned complaints at a hospital and was found to have a blood pressure that he remembers to be around 240 by 140 millimeters of mercury. He was admitted for the same and found to have a serum creatinine of 16 milligram per deciliter, and underwent emergency dialysis through a catheter in his neck. He underwent 2 sessions of dialysis. He remembers that on evaluation, he was told that both his kidneys were shrunken and his hemoglobin was 6. He does not remember being told any leakage of protein or blood in his urine. There was no history of any swelling over face or feet, no history of any reduced urine output, no history of passage of frothy or cola colored urine, no history of body aches, bony pains, or fractures secondary to mild trauma, no history of any use of any alternative medicines, history of recurrent UTIs or enuresis in childhood. There was no history of any joint pains, rashes, ulcers, any redness or dryness of eyes, or any pigmentation or tightness of skin. During this, after receiving 2 sessions of dialysis, he recovered and his creatinine settled to 4 milligram per deciliter, and his blood pressure also settled. He was discharged on conservative therapy back then and was advised to plan for a transplant because of his failed kidneys. He was prescribed 3 blood pressure medications that he remembers and an injection to increase his hemoglobin. However, over the subsequent 4 months, he left all these medicines and there was a loss to follow up. He started taking alternative medicines and presented again to the hospital in June 2014 with severe breathlessness and recurrent episodes of vomiting. This time again, he was admitted and was now found to have a serum creatinine of, he remembers to be around 24 milligram per deciliter. Again, dialysis was started through a neckline in the right side of his neck, and he was now shifted to a twice weekly hemodialysis. There was also an AV fistula created in the left forearm, and he remembers that this fistula became functional in 4 weeks. The patient remembers being vaccinated for hepatitis B, 4 doses over a period of 6 months, and receiving a shot of influenza at the time of discharge. At the time of discharge, his shortness of breath and other symptoms of vomiting, they resolved, and he continued with maintenance hemodialysis. He remembers becoming anuric by 2 months of being on hemodialysis. He remembers getting one episode of fever and chills during HD while he was on the right IJ catheter, and he was treated with IV antibiotics, and the catheter could be used for a further period. The body weight at the time of initiation of dialysis, he remembers, was 44 kilograms, and he was initiated on medicines to twice weekly medicines to increase his hemoglobin, along with iron injections and tablets for calcium and phosphorus that he remembers. He was planned for a transplant in March 2015, and a mother had volunteered for donation. However, 2 days prior to the scheduled transplant surgery, the patient had a fall from bed and had a fracture in his right humerus, which was managed conservatively, and the transplant surgery was postponed. Subsequently, his mother was diagnosed to have pulmonary cox and started on ATT. In January 2016, the patient himself started developing low-grade fevers with evening rise and reduced appetite, along with low backache. He was evaluated for the same, underwent an MRI of his spine as well, and was diagnosed to have port spine, and was started on anti-TB drugs, which he remembers he took for 6 months, 4 drugs for 2 months, and 2 drugs for the next subsequent 4 months. Since 2017, however, his mother, who was the proposed donor, has developed pain in both her knees, which has restricted her mobility, and developed hypertension, for which she takes two medications, and therefore his transplant was deferred. He has continued on regular hemodialysis since 2017, twice weekly. Currently, his post-dialysis weight, it varies between 58 to 59 kilograms, and his usual weight gain between dialysis periods is around 2.5 to 3 kilograms. Uh, Earlier, he remembers having frequent episodes of low blood pressure during hemodialysis. However, he says that the last episode of low blood pressure was 1 year back. He also used to have cramps during hemodialysis, for which he remembers taking injection levocarnitine. However, the last episode he remembers was somewhere around 2-3 years back only. There is no history of any episodes of very high blood pressure recorded during dialysis. No history of any nausea, vomiting, or severe backache during dialysis. He also has frequent episodes of high potassium, which he tends to get potassium-free dialysis for some duration regularly, and also has occasional episodes of low blood sugars. There's a history of itching over legs. There is no history of any chest pain, any palpitations, or any breathlessness. No history of any edema. No history of any body aches or bony pains. No history of any numbness or tingling in arms, palms, and feet. And there is no history of any recurrent admissions for infections or dialysis or any other dialysis related problems. He has used his left forearm fistula for the past 7 years. He remembers having a trauma at the site of surgery around 5 years back, which was managed conservatively. However, he has a visible swelling over the scar site. He also has two swellings in his forearm, next to which are the needle insertion sites. There is no numbness, tingling, any change in size or color of fingers, or any pain in the fistula arm. Sir, he uses fresh dialyzer with each dialysis. He's able to perform his
चलो
activities of daily living comfortably, and a wife is his primary caregiver. He is a, sir, this is my present history.
okay.
Uh,
So comprehensive history.
sir.
Quick two questions. What do you think is this etiological diagnosis? Just etiological diagnosis, because I think the purpose today which you have put the patient is to discuss the hemodialysis journey, right?
Yes, sir.
A quick question. What do you think was his etiological diagnosis?
Uh, Sir,
What
at
was his
present,
age at that time?
so 25 years of age.
Okay. And
Yes,
now he is 32.
30.
Okay. Does he have children?
No, sir. He has been
No, he
married
doesn't
for
have
10
children.
years, but he does not have
Okay.
children. Yes.
So what do you think his primary diagnosis was?
Sir, at this young age with presentation of high blood pressure, sir, my likely primary etiological diagnosis would be a chronic glomerulonephritis. For him.
No history of pedal edema, no
No,
history
sir.
of fluid.
Although he
So
does not have any
yeah.
history of either pedal edema or anasarca or any history of macroscopic hematuria. Uh,
Mhm. Can you think of something else?
uh, Sir,
Supposing it was, see, initially it was malignant hypertension, right?
yes, sir. Yes, sir. The acute
Whether it
presentation.
was
Yes, sir.
whether it was chronic glomerulonephritis,
Yes. The
whether it
acute
was
presentation for him
primary
was malignant
malignant
hypertension. Yes.
hypertension. What could have been the other causes of malignant hypertension?
Uh, Sir, malignant hypertension, either, sir, patients are of chronic hypertension who are not taking treatment.
पर ये तो chronic hypertension नहीं था ना, तो
Sir.
स्टार्ट ऑफ ही हाइपरटेंशन malignant hypertension से हुआ ना, इसको तो कोई
Yes, sir.
सीक्वल भी नहीं थी.
Yes, sir.
हम्म?
Yes, sir.
और क्या causes सोचोगे malignant hypertension में?
Sir, for diseases like, sir, renovascular hypertension, sir, patients who have systemic sclerosis or systemic vasculitis.
Systemic sclerosis in a male, in a 30-year-old
Yes,
male, मतलब
sir.
मजेदार वाली बात नहीं होगी. चलो आशीष तुम पूछो इससे. Ask him something.
Yeah. So regarding the etiological diagnosis, as you said, the chronic glomerulonephritis. If you are thinking of chronic glomerulonephritis, which particular histopathological diagnosis you are thinking of, which has progressed to CGN and then end-stage renal disease
Sir,
so fast?
in this age group, sir, in second decade of life, sir, a third decade of life, sir, possibilities of FSGS and, sir, IgA nephropathy.
Yeah. So FSGS usually presents with the nephrotic range proteinuria with hypertension with symptomatic disease. So
Yes,
this
sir.
patient should have some degree of edema and hypertension diagnosed, which has led to chronic glomerulonephritis. Yes, IgA nephropathy sometimes presents with like some nephrotic proteinuria, just
Yes, sir.
active urine sediment, which is usually missed, and the patient presents with a chronic
Yes.
disease. Okay, and the other things you are thinking of vasculitis or something like, they also present with the catastrophic clinical
Sir,
presentation.
present.
So in this patient, giving some vasculitis diagnosis, small vessel, or like you are saying scleroderma or something, they are not fitting in this. Okay, and then again renal artery stenosis in young male. So obviously the causes are usually atherosclerosis, which are leading to ischemic nephropathy, and they are evident in later part of the age. The other FMD is usually doesn't present with the CKD and high blood pressures. Okay, so it will be very difficult at this point of time to exactly knowing about the etiological disease. So, but
इसको
you should
at the
have.
start, yeah, sorry, खत्म कर लो तुम, sorry.
Yeah, sir, go ahead, sir.
At the start of his illness, was it preceded by diarrhea or something, Abhishek?
No, sir. No, sir. So, I have taken the history, sir. No history of suggestive of
At
any
the
TMA.
start of illness
हाँ sir. He
कुछ भी नहीं
only
था,
नहीं
कोई
sir.
alternate medication वगैरह कुछ भी नहीं था.
नहीं sir. Insidious onset headaches इसको for around 2 months हुए थे, which progressively
वो तो
increased in frequency and severity. He did take some analgesics for the relief of headache, but that was only this period of 2 months. Following
कोई
which,
डायरिया या कोई
नहीं
ऐसा इवेंट नहीं था जिसमें हम टीएमए ला सकें.
नहीं sir, TMA नहीं sir.
नहीं ला सकते, बायोप्सी नेचुरली हुई नहीं.
So was any there history of illicit drugs intake or something like that? Because they
No, sir.
sometimes presents with the kidney diseases and very high blood pressures like cocaine use or something like that,
but
chronic
sir,
use of
no,
that?
sir. He does not give any history of any high risk behavior or illicit
Mhm.
drug use.
Okay.
Okay. So now he's 7 years on dialysis, right?
Yes, sir.
Tell me the. आप पूछो आशीष, आप पूछो इससे.
Yeah.
Ask
So
something.
yeah. So what all the like patient has presented to you with the CKD stage 5. So initially you are going to start the patient on hemodialysis. So what all
Yes, sir.
things, how will you evaluate the patient initially to know what is the all the biochemical parameters and to make the etiological diagnosis if possible. So how will you approach?
Sir, approach at presentation 7 years back would have been,
Initially,
sir.
yeah, at
Yes,
7 years back.
sir. Ancillary investigations like the complete hemogram with an ESR and peripheral smear. Sir, the renal function tests, his serum protein and albumin, total serum protein and albumin. So his urine routine and microscopy along with spot PC ratio or albumin to protein creatinine or albumin to creatinine ratio. Sir, an ultrasound of the abdomen at presentation to check for the size and echogenicity of the kidneys. And sir, at presenting at 25 years of age with malignant hypertension, even a renal Doppler, sir, to check for renal artery stenosis. Sir, these would then, sir, I'd also like to check for end organ damage in other organs, especially eyes, sir, because he had presented with malignant hyper. So, fundus examination for retinopathy and papilledema, sir, an echocardiography and electrocardiogram of the heart to check for any, sir, chronic hypertrophy, left ventricular hypertrophy at that moment. Then, sir, at that presentation, if his kidney sizes would have been normal, sir, his complement levels of his complement factors to check for any inflammation that is going on, sir.
So presumably, like at presentation, his hemoglobin was 8 grams.
He remembers it to be six actually.
Or so it was 6.
Yes.
So and the patient was immediately started on hemodialysis because of the high creatinine values.
Yes. Yes.
Okay, so how will you manage the anemia in this patient with the 6 grams hemoglobin with patient started on dialysis? So what all special investigation you will do to evaluate the anemia and how will you treat it?
Sir, patients presenting with malignant hypertension, sir, we have to suspect the history of a thrombotic microangiopathy. So for that, sir, we need to prove microangiopathic hemolytic anemia. That is, we get an LDH levels. We also check for peripheral smear for schistocytes. So we need to rule out sir TMA for him. Then sir getting a iron profile and also his vitamin
Before
B12.
that, for hemolysis, what else you will check?
Sir, his Coombs. Sir, direct and indirect
Okay,
test.
Coombs test. Then
Yes.
to prove the hemolysis, what special investigation you will do?
Sir, schistocyte and LDH and reticulocyte count.
LFT.
Yes.
That is a basic test to know.
Yes, sir.
And then haptoglobulin.
Hemopaxin, haptoglobin. You have to enumerate everything, Abhishek. If it is asked in theory, now these things also become available. Yes, go ahead.
So in the peripheral smear, what will you see?
Sir, we see, sir, if this is a case of TMA, sir, we tend to see schistocytes, sir, which are deformed, fragmented RBCs, sir, basically.
When do you call schistocytes to be significant?
So it is more than 1% of the
1%, 2%.
1%.
Now you will do the iron studies. So what all you will do in the iron studies?
Sir, we check for serum iron, sir ferritin, sir transferring saturation, and his total iron binding capacity.
So I say there was no evidence of any cystocytes. The LDH was normal. There was no evidence of hemolysis on the peripheral smear. Okay, so now the hemoglobin is 6, and his T set was 15, and his ferritin was 100. So what will you the next step?
Sir, the first step, because he has a low T-sat, which is the most important marker for iron deficiency in CKD. So first step would be to replenish his iron stores, which would be by using IV iron therapy, sir, for him, and monitor the rise in hemoglobin and reticulocyte counts after iron therapy, sir.
So with the KDIGO guidelines, what are the levels they have mentioned to give the IV iron therapy?
Sir, they say, sir, just for transferring saturation, sir, they say the cutoff is less than 30%. Sir, they say not to give iron if TSAT is more than 30, and to give for iron if the transference saturation is less than 30%. Second, sir, for ferritin, sir, it is that patient can be given if his transference saturation is below 30%, we can give iron even.
TSAT is less than 30%, then?
Sir, for cutoff for ferritin, sir, we can give iron up to sir 800. What they say, sir?
So if the ferritin is less than 200,
yes, sir. Yeah,
and the TSAT is less than 30%, IV iron is recommended. Yes. Okay. So if TSAT is like less than 30%, but ferritin is like 800, so will you give IV iron or not?
Yes, sir. They say up to 800 of ferritin, sir, you can.
So in such cases, like ferritin is also a marker of acute phase reactant.
Yes, sir.
So whether it is inflammation induced or it is true iron deficiency, what test you will do?
Sir, we do a reticulocyte count or
there is a simple test. In COVID, what do you do for seeing the inflammation? CRP. Yes. Okay, so that is one test you can show inflammation is there or not. Yes. Or if you want to more precise, then hepcidin is the test, which is not freely available, but it is a marker of inflammation. So you can differentiate between the absolute iron deficiency and functional iron deficiency by using these tests. Okay.
Can you Ashish, can I ask him, can you tell him how iron is regulated in the body in 5-6 simple lines, and some 2-3 latest trials about IV iron in CKD situations?
Sir, iron
so
absorption.
Then we move on to some other dimension. Yes.
Sir, iron absorption in the body, sir, it is sir, in the ileum, sir, the iron is absorbed.
इलियम क्या बोल रहे हो भाई? B12 होता है वहां पे एंड पार्ट में. चलो मान लेते हैं
सर, इलियम में तो बहुत कम होता है. The iron, sir, it gets absorbed into the intestinal sir cells.
कैसे how?
Sir, it from
कैसे? फटाफट बताओ यार, अभी बहुत चीजें पूछनी है. तो हीमोडायलिसिस की तो मास्टर क्लास होगी ना आज.
Yes, sir. Sir, iron gets absorbed into the in the ferric form and gets converted into
ferric form. क्या बोल रहे हो? Ferrous C, the only way iron can cross the enterocyte is ferrous.
Yes, and gets converted.
DMT1, DMT2 वहाँ बैठा होता है. और बताओ, चलो.
Sir, then it gets converted to ferric form and gets attached with sir and gets stored in the cells. Sir, from the
इतना simple थोड़ी बता
intestinal epithelium, sir.
You have to tell us some basically some transporters क्या वहाँ बैठे हैं भैया. 25-30 हैं, लेकिन 5-6 तो गिनाओगे. 5-6 तो मुझे ही याद है यार. अभिषेक ये तो गिनाना पड़ेगा। नहीं बेटा, फेरोपोटिन पढ़ो, हेप्साइडिन पढ़ो, ट्रांसफेरिन पढ़ो।
ट्रांसफेरिन इज द ट्रांसफर प्रोटीन व्हिच टेक्स।
अब सुन लो पहले। DMT1 DMT2 होता है। सबसे पहले फेरस फॉर्म में आयरन अंदर आता है, DMT1 DMT2 उससे फैसिलिटेट करते हैं। हेप्साइडिन अगर बड़ा हुआ होगा तो उसको यही रोक देगा। देन फ्रॉम दी blood side it will get attached to transferrin. It is excreted by ferroportin. Again ceruloplasmin and these things will help. And again if hepcidin is high, this coupling will be stopped. Basically hepcidin क्या करेगा, आपको आयरन का मोबिलाइजेशन नहीं होने देगा, ना एंटेरोसाइट से, ना हिपेटोसाइट से, ना स्प्लीन से, ना आरी सिस्टम से, ये नहीं होने देगा आपका। सो आयरन विल नॉट गो टू मैरो। इसीलिए अगर किसी का फेरिटिन 800-900 है, जो आशीष ने पूछा था, और उसको आप आईवी आयरन दे रहे हो, वो आयरन अपनी जगह पे पहुंचेगा ही नहीं, बिकॉज हेप्साइडिन उसको रोके रहेगा। ओके, देन यू हैव टू थिंक ऑफ HIF1, HIF2, बिकॉज यू नो HIF2 आजकल इतने इंपॉर्टेंट क्यों है? नाउ दे आर थेराप्यूटिक परटर्बेशंस। क्या है वो?
सर बेसिकली जो hypoxia inducible factors 1 and 2, HIF2 is the one which is more significant for iron absorption and CKD sir. Sir इसमें होता क्या सर, they have basically sir, it is the oxygen deficiency that is caused so these are transcription factors sir, basically which stimulate your erythropoietin production. Sir, and they tend to get degraded by oxygen, sir, by hydroxylation of their proline.
कौन सी एंजाइम है?
एंजाइम कौन सा होता है?
सर proline hydroxylase, सर proline
PH1, ठीक है?
हाँ सर। सर
चलो आगे बताओ। हेप्साइडिन को कौन रेगुलेट करता है? आयरन से फिर आगे बढ़ेंगे, कहीं और चलेंगे। आशीष, आई थिंक टुडे वी हैव टू बी ऑन हेमोडायलिसिस, राइट?
Yeah, okay, yes sir.
हेप्साइडिन किससे रेगुलेट होता है?
हेप्सिडिन सर आई डोंट नो।
एरिथ्रोफेरोन, इट ब्लॉक्स हेप्साइडिन, ठीक है? चलो कोई एक दो ट्रायल्स के नाम गिना दो आयरन के ऊपर, तुमसे एग्जाम में जरूर पूछेंगे, नए नेफ्रोलॉजिस्ट तो जरूर पूछते हैं।
सर ये तो सर एक आयरन ओरल वर्सेस आईवी का सर पाइवोटल ट्रायल
क्या था? पिवोटल में क्या था? कितने आर्म्स थे?
सर 2 आर्म्स कंपेयरिंग सर ओरल आयरन थेरेपी टू आईवी आयरन थेरेपी एंड
2 आर्म्स थे या 3 आर्म्स थे? आयरन कौन सा यूज हुआ था पाइवोटल में? FCM यूज हुआ था या जो माल्टोज हुआ था? कौन सा आयरन यूज हुआ था पाइवोटल में? अगर ये पढ़ा होगा तो बता दो।
कार्बोक्सीमाल्टोज।
गलत जवाब। मेरे ख्याल पाइवोटल में सुक्रोज हुआ है बेटे, चेक कर लेना इसे, लेकिन चेक कर लेना। माय मेमोरी में बी फेलिंग। आशीष, आयरन सुक्रोज हुआ था, क्या हुआ था?
सर आई डोंट रिमेम्बर एग्जैक्टली, बट
मेरे ख्याल सुक्रोज हुआ था। आयरन मैक्डोवेल ग्रुप का बड़ा ट्रायल था ये,
बिकॉज़ इट इज अ ओल्ड ट्रायल, सो सुक्रोज मस्ट हैव बीन यूज्ड।
आयरन सुक्रोज हुआ था। What do you understand by Craig's syndrome? What is Craig's syndrome?
Craig's
इसी से कनेक्टेड है बेटे। अभी हम जहां पे हैं उसी से कनेक्टेड है, अभी गियर चेंज नहीं कर रहे हम। Craig's is cardiac renal anemia iron deficiency syndrome। पहले होता था ना CRS, कार्डियो रीनल सिंड्रोम, फिर हुआ कार्डियो रीनल एनीमिया सिंड्रोम क्रैश, अब हो गया कार्डियो रीनल एनीमिया आयरन डेफिशिएंसी सिंड्रोम। इसकी इंपॉर्टेंस पता क्या है? द इंपॉर्टेंस इज दैट इन I think around 18 to 20% patients, you will not have anemia, but you will have iron deficiency. And it also has a lot of implications in the management of congestive cardiac failure, which is piggybacking CKD5D. And otherwise also in cardiologists today use IV iron as one of the tools to manage congestive cardiac failure. So Craig's syndrome has a lot of importance, and about 17 to 20% patients have iron deficiency without having anemia. Chalo, go ahead. Ashish, pucho.
So you have given him IV iron. So what level of hemoglobin you will like to maintain in this patient?
Sir, hemoglobin levels between 9 to 11, sir, are recommended for this is not to go more than 11, sir. So hemoglobin levels are satisfactory between 9 to 11.
So if the hemoglobin levels are around 13 or something, what problems can occur with this patient?
Sir, with high hemoglobin, sir, people tend to have sir higher chances of sir heart failure. Uh, yes,
Heart
higher
failure.
chances of strokes. Strokes, and they have tend to have higher incidence of strokes at high hemoglobin levels.
Which study had shown this?
Sir, Revo.
Something like treat, create, cohere.
Find CKD, sir.
Find
Find
CKD.
CKD iron की है बेटे, वो iron की study है find.
Iron study. So erythropoietin की major studies are with the they had shown na, with the high erythropoietin use and higher hemoglobin levels, there are increased incidence of stroke. That was by in the treat study by Dr. Singh.
That was treat, sir.
Yeah. So the other studies like COIR study has also shown the increased cardiovascular risk morbidity. So they had to halt the study in between because they had more of the these end points in this study. Okay, so you what else, if with high hemoglobin, what else can happen? One is cardiovascular risk, morbidity, increased strokes. What else? Anything with the fistula?
Yes, sir. Increased chances of fistula thrombosis.
Increased chances of fistula thrombosis, and something for hypertension.
Sir, patients who ESA, sir, who use erythropoietin stimulating agents, sir, they tend to have higher hypertension. That tends to cause hypertension, sir.
So what are the side effects of IV iron?
Sir, IV iron, sir, per se, that can cause immediate allergic reactions, which in iron sucrose and other previous formulations could iron dextran could even be lead to anaphylaxis and life-threatening reactions. Then, sir, if iron overload occurs, patients can develop hemochromatosis with iron overload, sir.
And the oxidative stress and infections and all those things can be the side effects of iron. Yeah. So once you have repleted the iron stores and the patient is still having anemia, so what all other causes comes to your mind?
So then, sir, we also have to replete the other hematinics, sir, folate and vitamin B12 for these patients. And then after these are done, sir, patients of CKD, they also require, sir, erythropoietin agents, stimulating agents. If the anemia still persists after iron depletion.
So this patient must have been started on erythropoietin.
Yes, sir.
Yeah. So once the iron stores are repleted, at what dose you start the erythropoietin?
Sir, usually, sir, erythropoietin alpha that started at a dose between 50 to 100 international unit per kg. Sir, usually twice to thrice weekly is the recommendation. And then, sir, we measure their hemoglobin every monthly. And
so what is the level you expect to increase in a 1 month?
1 to 2 gram% of rise in hemoglobin every month is expected. If it does not occur, then, sir, we increase the EPO dose by another 25 to 50% each month.
And if a patient on hemodialysis and he is having like stable hemoglobins of 10 or 11 every every month you are doing, and suddenly you start feeling that the hemoglobin is falling, and all the other you have ruled out the iron deficiency anemia, you have ruled out the hemolysis or active infection. So what can be the causes?
Sir, patients who are on EPO therapy, if they start, sir, then sometimes, sir, they can have sir, pure red cell aplasia.
So how will you diagnose it, pure red cell aplasia, patient on erythropoietin?
Sir, they tend to have, sir, anti-EPO antibodies.
Okay.
Yes.
And before that?
Bone marrow examination, sir.
So pure red cell aplasia is diagnosed on. So what is the first basic thing to see in the peripheral smear or CBC?
Sir,
absolute reticulocyte count. So if it is less than, I think 10,000 or something like that, then you should suspect the PRCA. So this is the one of the important thing. And the other thing is, like the patient, your patient who is on on dialysis for last 6-7 years, and he is not now responding to your iron therapy or erythropoietin levels. So what else can be the cause?
So one that, sir, there may be continuous blood loss through dialysis or through GI tract.
What else? What is about hyperparathyroidism?
Sir, hyperparathyroidism, it causes, sir, destruction of the, sir, bone marrow, obliteration of the bone marrow, sir. That can lead to deficient synthesis.
So how the hyperparathyroidism causes anemia basically in these patients? Something related to FGF23?
Sir, FGF23 is the factor.
So do you know the mechanism? No. So these are the newer things you should know, the mechanism, pathophysiology. So you ask, please, sir.
Chalo. What are the common complications you see in hemodialysis?
Sir, there are acute complications that we see during hemodialysis. Sir, the most common is hypotension, sir, intradialytic hypotension. Sir, the next is, sir, intradialytic hypertension.
इंट्राडायलिटिक हाइपोटेंशन मरीज को हो रहा है. अब तुम्हारा मरीज फर्स्ट डिकेड कंप्लीट कर रहा है, क्या क्या पॉसिबिलिटीज हैं, क्या क्या सॉल्यूशंस तुम ऑफर करोगे?
सर, initially, sir, whenever patient develops intradialytic hypertension, first is that we immediately stop the ultrafiltration.
नहीं, वो सब मुझे मत बताओ, वो टेक्नीशियन करेगा ना. तुम्हें तो प्रिस्क्रिप्शन रिवाइज करना ना बेटे. वो तो टेक्नीशियन बंद कर देगा, सेलाइन दे देगा, पैर नीचे कर देगा, हाथ ऊपर कर देगा. वो सब नहीं मैं पूछना चाह रहा. What I am asking is कि अब उस पेशेंट को हाइपोटेंशन हो रहा है, कॉमन प्रॉब्लम है ना. Ask any of your colleagues.
Ultrafiltration.
क्या कर लेते हैं हम?
Dry weight.
What do we do?
Sir, we have to assess for the dry weight, sir. We are reaching a goal that is beyond his dry weight for that patient. And the
what do you mean by that?
Sir, dry weight is defined as the weight in which there are no episodes of intradialytic hypotension during dialysis, and there is no episodes of interdialytic hypertension is not seen, and the patient is clinically euvolemic, sir.
Dry weight is a point beyond which if you remove even little fluid, he will have hypotension.
Right.
Okay. So, अब उसको हाइपोटेंशन हो रहा है और टेक्नीशियन टेल्स यू कि डॉक्टर साहब इसको तो बीपी लो हो जाता है 2 घंटे के बाद.
सर,
नो what advice you are going to give to the patient?
Sir, so we have to, sir, monitor what is his usual ultrafiltration that he goes, and we have to establish.
तुमने बताया तुम्हारे पेशेंट को 2-2.5 लीटर निकालते हो पानी तुम पिछले कई सालों से.
Yes, sir.
That's what you are doing.
Yes, sir.
अभी उतना ही अब नहीं निकल रहा 2-2.5 लीटर. Then what's happening? Now what will you do? बहुत चीजें हैं इसमें. 1 घंटा इसी में निकल जाएगा. इस तुम rapidly आंसर करोगे because this is the very quixotic problem. क्यों आशीष?
जी सर.
Intradialytic hypotension is a big problem. Then we can go to nutrition, we can go to bone disease, we can go to long-term complications of dialysis like beta-2 amyloidosis, blah blah myelofibrosis. So, but this is a day-to-day very common problem. Let's
Sir,
spend 5 minutes here.
sir, monitoring his antihypertensive medications, his volume status. Also, sir, we can give, if problem not solved, sir, we can give midodrine on the.
अरे
Yeah.
यार,
Yeah,
शुरुआती
that is a
मिडोड्रीन से करोगे? मिडोड्रीन तो कभी काम नहीं करती बेटे. This is useless. How will you? First thing is you have to revise his dry weight.
Dry weight.
Supposing if you are going below the dry weight, the dry weight might have changed. He might have gained weight. He might have gained real weight, and if you are pushing it below, he'll have hypotension. Why does hypotension occur? What is the pathophysiology of it?
Sir,
Whenever you will remove more fluid from the extravascular compartment into
Sir,
the dialyzer,
yes.
then the amount of fluid which can be relocated from the interstitial fluid, you will have hypotension, right?
Yes.
और क्या करोगे? What else will you do?
So the
Sir,
patient you should evaluate for the important is the cardiovascular disease. You have to evaluate the patient for the cardiovascular disease, and then if there is, you will have to whatever modify the drug prescription, intensify the dialysis for the adequacy. Okay, so the patient is having global hypokinesia or having dilated cardiomyopathy, so that has to be ruled out and corrected accordingly. Then you have to rule out microvascular and macrovascular diseases. Like if the patient is diabetic or something like that, so they are more prone for microvascular disease. So again, they will also be prone for autonomic neuropathy. So long-standing diabetes, 7 years of dialysis. So autonomic neuropathy is one of the very common causes. So you will have to evaluate and correct accordingly. Okay, and then you will have to see the dialysis related factors also. Okay, like like if your temperature is going high, there is some thermal, then there is some venous dilatation. You have to see the temperature of the dialysate is appropriate or not. If the patient is having these technical problems have also to be seen. Okay, so then if patients have got like some other diseases, like he had some diarrhea, vomiting in the preceding days or something like that, or if his antihypertensives are now getting higher. So these are all treatment related plus you have to see and correct all those things. Okay.
Can you do anything with the dialysate fluid?
Sir,
Can you tell me the
reduce
composition
the
of dialysate fluid?
Sir,
Temperature बता दिया आशीष ने. He told you temperature.
Yes, sir.
What else?
Yes.
He told you temperature. Tell him not to eat. खाना खाने से what difference does it make? By the way, if the patient takes food, why does BP go down?
Sir, the blood supply, sir, goes to the gut, and there is
total peripheral resistance reduces. That is the answer. So what else will you tell me? The composition of dialysis fluids. How many type of fluids you have seen?
Sir, dialysis fluid, sir, it has part A and part B. Part A, which is the acidic component, and part
tell
B.
me the composition when both are mixed, or when the standard dialysate acetate fluid we used to use is after mixing. What is the composition and the types of dialysis fluid you know?
Sir,
this is also related to this question of hypotension.
Sir, the dialysate fluid, sir, it has the sodium levels, sir, they are between 135 to 140, sir. Sir, potassium between 0 to 4. Sir, calcium concentration between, sir, 1.2.
बहुत बड़ी रेंज बता रहे हो, बहुत बड़ी रेंज बता रहे हो.
So potassium, sir, we use 3 bucks, either K0 or potassium at 0, potassium at 2 milliequivalent, or potassium at
स्टैंडर्ड डायलिसेट फ्लूइड में कितना पोटेशियम होता है?
2 milliequivalent. 2
और स्टैंडर्ड CAPT बैग में कितना पोटेशियम होता है?
सर नील, 0.
गुड. सो स्टैंडर्ड डायलिसेट फ्लूइड में पोटेशियम इज 2, सोडियम इज
सर 135.
135 ज्यादा बता.
तो 115 होता है.
कैल्शियम कितना होता है
सर?
हाउ मच इज कैल्शियम?
1.25 to 1.5. 1.5
कैल्शियम
मिलीक्यूवेलेंट्स.
मिलीक्यूवेलेंट्स या मिलीमोल दोनों में फर्क है. कैल्शियम में उसकी वैलेंसी 2 है. यू हैव टू टेल मी वन. सोडियम और पोटेशियम में चल जाता है मिलीकुलन मिलीमोल्स, कैल्शियम में नहीं चलता, करेक्ट?
सर it is 1.25 milliequivalent, sir.
Millimoles. So it will be 2.5 milliequivalents. It is 1.25 millimoles. So can you do something with calcium for hypotension management? Something with calcium magnesium. अच्छा ये बताओ किसी को, अब तुम्हारे इसी पेशेंट को, चलो बाद में सोचना पढ़ना इसको जो भी सुन रहा हो, this patient is now not getting maintained by two times a week dialysis. He is getting hypotension, he is getting intradialytic hypertension. What else can you offer him? Will you change his dialysis modality, dialysis
sir,
prescription?
We can either, sir, prolonging either increasing the frequency of his dialysis, or sir, prolonging the duration of his dialysis session, or you can switch him, sir. He's on hemodialysis, sir. We can offer him, sir, hemodiafiltration.
How will hemodiafiltration help?
So hemodiafiltration, sir, basically, sir, the hemofiltration part, sir, it helps in removal of sir, middle molecules with the removal of inflammatory parameters like, sir, cytokines and TNF, and also the large amount of volume that we give during
hemodiafiltration. The large hemodiafiltration में तो तुम पानी, you take more fluid out, so you'll become more hypotensive. So how will hemodiafiltration act in terms of physics? You understand my question?
Yes,
in hemodialysis, you were removing 2.5 liters. Now hemodiafiltration, you have added convection also, correct?
Yes, sir. Yes, sir.
So that will also take out more fluid. So in fact, he should become hypotensive. But in hemodiafiltration, certainly hypotension is less than ordinary hemodialysis. Why?
Sir, we use, sir, the fluid that is the ultra pure fluid that is used in hemodialysis. That itself.
That is one reason. That is one reason. So ultra pure fluid, very, very biocompatible membranes. And what else? What else is the reason that in hemodiafiltration hypotension will be less? I'll give you a hint. If you do a scuff in a patient,
yes, sir,
in cardiology ward, they will ask you to do scuff.
Yes, sir.
Do you face hypotension?
No, sir.
So to all listeners, for hypotension, the osmolality of the serum is very important. In dialysis, when the sodium translocates rapidly, the osmolality falls, which leads to shift of fluid from the extravascular compartment into the intracellular compartment and other extra. So whenever sodium is taken out, you will have more hypotension. So in scuff, you will not have hypotension. Similarly, in online hemodiafiltration, because of the convection modality, the concentration of sodium will remain better compared to hemodialysis. That is the reason. It is the game of osmolality. You need to go and look at it carefully, all of you who are listening to this case presentation. Okay? Acha, tell me, how will you measure the adequacy of this patient? What are the tools of measuring adequacy of this patient?
Sir, dialysis adequacy, sir, can be measured by the urea reduction ratio. That is
yes, what is that?
Sir, we measure, sir, both pre-dialysis and post-dialysis blood urea, which is post-dialysis is either 2 minutes after dialysis or during at the end of dialysis by reducing the blood flow rate to 100 ml per minute for 15 seconds. Sir, ideal, sir, URR should be more than 65%, sir. Then, sir, the next is, sir, we use urea kinetic modeling with single KT by V.
What is KT by V and what is EKT by V?
Sir, KT by V is, sir, single pool KT by V that we use only as the single session urea kinetic
Matlab
modeling.
Kya? What do you understand by KT by V?
Sir,
and who introduced this term? Who introduced this term? This was introduced by Sargent and Doe in NCDC trial way back in 1976. So what is KT by V and what is EKT by V?
Sir, KT by V is basically, sir, the ml of the K is the, sir, amount of urea that is removed from the body.
No, K is not that. K is not the amount of urea. K is not the amount of urea. What is K? इसको पढ़ लेना है ना, because time is finite. We have only, I think, 15-20 minutes left. Everybody should read KT by V. And can anybody say what is E KT by V?
Sir, E sir is the equilibrated KT by V. So basically, sir, what happens is because of the shift of these small molecules like urea from the interstitial to the intravascular compartment, after dialysis it takes certain time. So for EKT by V, sir, we wait for some time to take the.
नहीं, what do you mean by EKT by V? EKT by V से मतलब क्या है?
Equilibrated
Yes,
KT by V.
equilibrated.
So once there equilibration occurs
Yes.
in the blood from
which is the major component of the body which contributes to this equilibration. See, KT by V is basically a blood phenomena. The amount of urea you are removing from blood is what you are measuring. What is EKT by V? Which is the other compartment which is contributing mostly to this equilibration. But urea will be present everywhere. No? It will be around the brain, it will be in the cells, it will be in the heart, it will be in the muscle, it will be in the bones. Urea is omnipresent. It has first pass kinetics. It's like 100% diffusible. What is the molecular weight of urea?
60 da.
Good. So what is EKT by V? EKT by is when it is equilibrated with the urea from the muscle. And if you are doing EKT by V, what is the recommendation? How much EKT by V dose should be there?
EKT by V, sir, is 1.2.
No.
Single
1.2 है तो फिर KT by V कितना हो जाएगा?
1.4, sir.
Yes. So 1.3, 1.4, 1.4 is a good single dose dialysis. Yes, EKT by V could be as low as 1.05, 1.V. We must know URR, we must know KT by V, all components. K की importance here is once you know K, depends upon 6-7 factors. T is the amount of time the patient is on dialysis, and V is
volume of distribution of urea, which is equal
basically
to
it is the total body water. Total body water, right? It is the total body water. So that is easy to calculate. 60% of the patient true weight is the total body water. Okay. Now, supposing I say that this patient, one thing you have said is SDF. What else?
Sir,
if you look at this formula, you have to increase time. How will you increase time?
Sir, we can give longer sessions of dialysis, sir. So, for example, nocturnal.
Yes. What is nocturnal dialysis? Where was it propagated mostly? Any major trials you have read about nocturnal? What is the advantage of nocturnal hemodialysis? If you have read it, you will tell me, Abhishek. Right. What is the advantage of nocturnal hemodialysis? Roughly what duration it is done? And what are the modalities to do? At least theory we must know. We may or may not be doing types of nocturnal dialysis, the advantages. Okay, the advantages of nocturnal dialysis, दो बता दो मेरे को. So I'll understand you know the concept. That's why I'm asking.
Sir, one that it increases the efficiency of our dialysis. Sir, two that sir patients can be ambulatory.
तो ये तो तुम्हारा हेमोडायलिसिस वाला मरीज एम्बुलेटरी नहीं है. 8 साल से एम्बुलेटरी है यार. You are not giving the right answer, beta.
So the two major things are
the control of blood pressure will be perfect. He will not require any antihypertensive medicine because most of the blood pressure in CKD5D is volume driven. Yes. And if you are doing 6 hours, 8 hours of nocturnal dialysis, his control of blood pressure will be so perfect that he will not require antihypertensive medication, number one. And somebody has very rightly said phosphorus clearance will be perfect. He will not require any phosphate binder. In fact, he may not even require erythropoietin because the erythropoiesis will be improved. Ashish was saying about PTH and all those things, right? So it will be a near. Basically, you are approaching in terms of time the amount of dialysis a normal person does. So nocturnal dialysis can be at home hemodialysis, or a patient can come to the center in a designated room. He sleeps there, and then he goes back home. So that is nocturnal hemodialysis. Okay. So how will you, what is NPCR, small NPCR?
Sir, that is normalized protein catabolism.
What does it tell you?
Sir, basically, the creatinine kinetics. Sir, usually tells us the amount of food intake. So for the patient.
You expand the word protein catabolic rate.
Yes, sir.
So protein catabolic rate is the amount of catabolism of protein in your body.
Yes, sir.
How do you measure it? It has to do with dialysis adequacy. That's why I'm asking you. चलो इसको देख लेना. Okay. Okay. आशीष पूछो, तुम पूछो.
So your patient has a history of fracture of humerus.
Yes, sir.
I think after a fall or something like that.
Yes, sir. Yes, sir.
Yeah. So do you think it was a pathological fracture or?
Yes, sir. He said, sir, that it was only fall from his bed. So that was a trivial trauma only, sir.
So what could have been the contributing factor?
Sir, patient with CKD, mineral bone disease, sir.
So what evaluation is needed for that?
Sir, for evaluation, sir, we need the patient's calcium, phosphorus, 25 hydroxy, vitamin D, and PTH levels, sir, to be monitored.
So at what level of GFR, even patient is not on dialysis, all these abnormalities start?
Sir, usually, sir, even stage 2 CKD, sir, some amount of sir hyperparathyroidism, but that usually is transient, sir.
And when the clinically evident disturbances in calcium phosphorus start, at what level?
Sir, that is GFR less than 30. GFR is less than 30 clinically evident. So stage 4.
So this patient has increased PTH, secondary hyperparathyroidism. So what are the causes of secondary hyperparathyroidism in such patients, which cause to weak bones?
Sir, basically, sir, in CKD, sir, there is tends to be retention of phosphate.
Yes.
Now, sir, because of this retention of phosphate, sir, there is a reduced synthesis of the 1-alpha hydroxylation step of vitamin D synthesis is reduced. So this reduces the calcium absorption from the intestines, sir. And this state of, sir, hypocalcemia. Hypocalcemia is a trigger for PTH synthesis, sir. This leads to, sir, hyperparathyroidism.
So what are the various bone lesions which are present in these patients? And how will you diagnose? What is the gold standard for that?
Sir, usually, sir, it is the osteitis fibrosa cystica, or patients may have, sir, osteomalacia. Sir, on the other spectrum is, sir, the adynamic. Sir.
So what are the risk factors for adynamic bone diseases, which are more prone for the fractures and all those things?
Sir, adynamic bone disease, sir, usually seen, sir, in patients who are well controlled, sir, better control of PTH, or they are using sir, phosphate binders initially. Sir, patients with diabetes, they have higher risk factor of developing adynamic bone disease. Those who have undergone vitamin D therapy, sir, patients with CAPD, sir, they tend to have hypoparathyroidism, and this leads to, sir, reduced bone formation and higher risk of fractures.
So what is the gold? So what is the gold standard for diagnosing these bone lesions?
Sir, bone biopsy.
So we don't do bone biopsies like regularly. So you will go by the clinical examination and basically lab findings of, so to know the. So the patient has a high PTH of more than 1200 and phosphorus of more than like something 9 or 10. So what will you start first and why?
Sir, we have to give these patients sir phosphorus binders and provide adequate hemodialysis.
So which phosphate binders you will like to use?
Sir, we can use sir both sir calcium containing as well as non-calcium containing phosphate binders.
So where will you like to use the calcium containing phosphate binders?
Sir, in those patients who have higher risk of developing adynamic bone disease
Or having hypocalcemia.
hypocalcemia.
So there you will use, or if the patient is already having hypercalcemia or something, you will use non-calcium binding
Non-calcium.
of non-calcium phosphate binders.
Yes.
Okay. And what else?
Uh,
What other drugs are available?
Sir, so there is sir calcium salts of carbonate and acetate. Sir, there is sevelamer and sir lanthanum and also sir aluminum hydroxide.
So do we use aluminum hydroxide?
Sir, not anymore. Not really.
So
Why?
Previously it was used as a phosphate binder, but nowadays we don't use. What were the problems with the aluminum hydroxide?
So basically, sir, causes aluminum absorption, which leads to sir, which is seen in dementia, neurological deficits in long-standing dialysis patients. Sir.
And
Sir, deposition of aluminum and
one is
Anemia. Severe
anemia.
anemia. Microcytic anemia. Severe. And bone fractures.
Yes.
How much phosphorus a person takes in his diet?
Sir, around sir, usually sir,
मैं पूछूं ना, दो तीन चीजें पूछ लूं.
In a week, sir, around 4,800.
कैसे? डाइट में 4,800 क्या लेता है? Normal person. Normal phosphate is like about a gram 1,200, है ना? A gram of phosphorus. 600, 800 मान लो, 8 7s are 56. Okay, so how much phosphorus is removed in one dialysis session?
Sir, usually in in one dialysis session, sir, around so 400.
How much phosphorus is removed in one dialysis session? Then what dietary precautions you tell to your patients that the phosphorus, what types of phosphorus are you know of? Like food items rich in phosphorus and types of phosphorus.
Sir,
safe phosphorus, unsafe phosphorus.
Sir, natural and synthetic phosphates.
Yes. Sir. ठीक से और बताओ यार, बता रहे हो.
Sir, natural and synthetic phosphates sir usually होते हैं sir. Those
किसमें होते हैं?
phosphates
Synthetic कौन से हैं?
Sir, food items in which it is used as preservatives, sir, for packaged foods and sir colas and drinks sir में sir phosphates जो होते हैं sir वो synthetic phosphates.
Yes. Colas वगैरह में होता है phosphorus which is inorganic.
Yes.
And it is a very high concentration. The problem with this phosphorus is that its absorption in the gut is 100%. Yes. Whereas the phosphorus which you eat in the diet, like wheat, pulse, meat, they are bound with the other ions. So their absorption is 30%, 40%, so you will not get it. That's why in our patients, we tell them not to take colas, not so much for potassium, but for phosphorus. This additive phosphorus, 100% will be absorbed. That is why we tell them not to eat. And then the bound phosphorus is not so well absorbed. And in dialysis, you will never be able to remove more than 200 milliculents of phosphorus in a good session. That is why these patients are perennially in a state of hyperphosphatemia in spite of 3 good dialysis. It's impossible to maintain their phosphorus. Only thing is, if they are not eating well, they become very severely malnourished, then you might be able to get a handle on their phosphorus. So precaution of keeping the phosphorus is in dietary modification. Chalo. So what are loser zone? Have you heard of term loser zone?
Sir, these are characteristic features of renal osteodystrophy, where sir they are prone to fractures because they're severely osteomalacia.
Osteoporosis अलग चीज है. Don't say osteoporosis. Don't confuse.
Sir, osteomalacia.
It is a disease of osteomalacia.
Yes. Osteomalacia, because of severe osteomalacia, there is no mineralization of the bony matrix. So they tend to be, sir, radiolucent areas on
Very good.
X-ray.
You know it. So it looks like there is a fracture line.
Yes.
It's a pseudo fracture line. Good. So in such patients, if there is adamic disease, I think Ashish has already discussed with you.
So this patient had a history of pot spine also.
Yes, sir.
And so the hemodialysis patients or CKD patients are more prone for infections.
Yes.
Yeah. So what all precautions you will take to prevent infections in such patients? Dialysis patients basically to prevent the infections. So what precaution you will take?
Sir, one is, sir, for patients on hemodialysis, one would be, sir, prevention of blood-borne infections. So that is with dialysis sessions, sir, having proper aseptic precautions for both initiation, while initiation and closing of dialysis. Secondly, sir, patients for their diet, sir, they should cook, they should eat, sir, water, and their diet, they should eat only fresh meals, sir, to be cooked on the day, and practice good oral hygiene, sir.
So that is for everyone. That is for everyone. So what about the vaccinations in such patients?
Sir, vaccinations, sir, to be given, sir, we give, sir, vaccines for viral diseases like, sir, hepatitis B, pneumococcal, and, sir, influenza vaccines, and now, sir, COVID vaccines also.
Now?
COVID, sir.
COVID. Okay. Anything else?
Sir, annual influenza vaccines.
So if such patients don't mount the good antibody response to hepatitis B or something like that, so what will you do?
Sir, we give booster doses, sir. So hepatitis B, sir, in CKD patients, it is seen, sir, that they have B vaccine. They don't tend to give have good responses. So we give the double dose of the vaccine, and we use frequent boosters of the vaccine, sir.
Somebody is writing zoster vaccine. So it is indicated for everyone, or there is some age limit or something like that for zoster vaccine? So you give to each and every patient of hemodialysis, or there is some cutoff of age beyond which you give zoster vaccine?
Sir, adolescents.
So it is 50 years or more than 50 years of age, you give zoster vaccine also to these patients. Okay.
What is Clotho? Tell me something about Clotho and FGF23. फिर बोन से निकले आशीष. What is Clotho? What is FGF23? Tell me 5-6 sentences about Clotho and FGF23. Mechanism of action of FGF23. How it is back regulated. What does Clotho do there?
You know from where the name Clotho comes? It is a name of Greek god, which is something like, I don't remember what is they worship for. So what is the relation between FGF23 and Clotho?
I have not read.
Chalo, kuch aur pucho. Good. That is the way it should be. To all the students who don't know the question,
do read about Clotho.
Yes, सब लोग पढ़ लेना Clotho के बारे में. FGF के बारे में, tell me something about FGF. Forget Clotho.
Sir, FGF23, sir, basically again, sir, in CKD, when there is increased phosphate retention, sir, it tends to increase your FGF23, and it itself, sir, causes, sir, cardiovascular. It is responsible for cardiovascular.
What will it do to vitamin D?
Sir, it reduces the synthesis of vitamin D, sir, and also, sir, it has been
vitamin D antagonist.
Yes. And also, sir, it has been shown to be responsible for the cardiovascular
Yes.
side effects.
Okay.
So from where
So
the
what are the
FGF
other?
From where the FGF23 is created in the body? Osteocytes and osteoblasts in the bones. Okay. So from there it comes. Sara, पूछिए please.
Okay. So now your patient is in 10th year of dialysis. What are the common complications you envisage?
Sir, commonly, sir, patients of dialysis, they tend to have, sir, cardiovascular morbidity, which maybe, sir, most common is, sir, left ventricular hypertrophy. The patients will have.
How can you reduce his left ventricular hypertrophy since you get the patient at a very young age? What you could have done? This shows maximum beneficial effect upon LVH. One single surrogate, and we never are able to do it. Systolic blood pressure control is single most important factor to govern LVH. If we can keep their systolic blood pressures under 130 for most of the time, they will not have so much of LVH. And what kind of a microvascular disease they have? What is it really called? If you look at a section of their myocardium, what will you find there?
Arteriosclerosis. Calcification.
Yes, good. So they have more of medial disease. Medial disease. Atherosclerosis is the cholesterol-driven disease is more of intimal disease. Atherosclerotic plaques are there. All those things are there. They will also be there, especially in a diabetic CKD. But in a pure homegrown CKD 5D, they will have a lot of thick media, lot of hypertrophy, and a lot of calcium. If you have ever seen a 2D echo of CKD 5D patient, you find there's so much of calcium. The echoes are very bright. Echocardiographers have a good time in doing echoes because the windows are so good. They have a lot of calcium sitting there, Monkenberg calcification. Yeah, that's right. Okay. So systolic blood pressure control remains the very important thing. Another point is, you agree with the therapy of ATT in your patient, 6 months, that too for port spine?
No, sir.
What is the recommendation?
Sir, actually, sir, now, sir, although they recommend as part of our DOTS guidelines, sir, they say for EPTB again 6 months only, sir. But however, it varies.
But Government of India has kind of denigrated DOTS, if I remember correctly.
So this was.
I think we are coming out of DOTS age. Are we not?
Practically not.
But theoretically, yes.
Yes.
Okay. So,
what other long-term complications of dialysis 10 years? One is cardiovascular, second is vascular access related.
Vascular access related, sir. Patients may have, sir, dialysis access steal syndrome, sir.
And before that,
sir, high output
cardiac failure, aneurysmal dilatation.
Yes.
And then,
sir,
so you are puncturing the fistula for last 10 years.
Yes, sir.
So
thrombosis.
The vessel wall where you are piercing has become weak. So what precautions you should take?
Sir, ID, sir, it is recommended to use the railroading technique to puncture the fistula.
What is that?
Sir, in railroading, sir, we use a segment. We use 1 to 2 millimeter, a site 1 to 2 millimeter distant from the previous insertion site, and after 6 to 7 cycles, sir, we come back to our original site of needle puncture, sir.
What is buttonhole technique?
Sir, in buttonhole technique, sir, we use the same site of needle puncture every time. So, although, sir, it tends to cause more aneurysmal dilations, but it causes a fibrous sheath, sir, which reduces the insertion pain on
So for the patient, it is advantage. So
Yes.
they feel less pain, and the needle insertion is easy technically as compared to the other technique.
Yes.
Okay, but it can lead to more of ruptures and aneurysmal dilatations. Okay, what else? What is steel phenomena?
So in steel phenomena, sir, patients who develop peripheral vascular disease, especially in the AV fistula, sir, because of poor flow in the sir, ulnar artery of that arm. So patients on dialysis, sir, in the dialysis hand, sir, they tend to develop complaints of sir when dialysis is initiated, sir, they tend to develop complaints of tingling numbness, and it may actually progress to sir, full-blown infarction of digital gangrene.
Pain and digital gangrenes.
Gangrenes.
Okay, so before that, you will have to diagnose it and correct it. Okay. So what tests you do clinically?
Sir, at the creation, before the creation of AV fistula, sir, we do the modified Allen's test, sir. So in modified Allen's test, sir, we ask the patient to clench their fists and then occlude both their radial and ulnar arteries. We ask them to clench their fist till the time that their palms are
Blanched.
blanched, and then we remove the pressure from the ulnar artery, sir, to see for perfusion. Usually, sir, it should occur between by 5 seconds. Sir, if it occurs, this is a positive modified Allen's test. If it does not, then, sir, it shows that insufficiency of the ulnar artery.
What is
What
the
are the
most
complications?
what is the most
What are
common
the-
complication of central venous catheters long term?
Sir, long term, sir, CV, central venous stenosis itself. Short term, so they are more prone for infection.
Other complications? Tell us something about pruritus. How do you manage pruritus in a dialysis patient?
Sir, again, sir, pruritus, sir, again, may be caused because of high parathyroid hormone levels, and sir, for pruritus, sir, again, sir, first is to give adequate dialysis to the patient. Sir, we can give, sir.
So what are the modifiable factors of pruritus, and what are the non-modifiable factors of pruritus?
Sir, control of
अभी कितना time है हमारे पास? I think we are reaching.
We are over.
Reaching time, है ना? So I think I'll ask this one more question after this, Ashish, and then I'll sign off. जल्दी बता दो बेटा pruritus बारे में. Otherwise, I'll go to the next question.
Sir, modifiable factors would be, sir, the PTH and phosphorus levels for the patient, and non-modifiable.
Heard of opioid hypothesis in pruritus? And the new drugs which have come for pruritus, उसका क्या नाम है? What is its name?
So diflycphalin.
Diflycphalin. Okay. Who is the final two questions from me, and then Ashish can ask whatever he wants. Who is called the father of dialysis? I'm fond of a little bit of history. Who is called father of dialysis? Anybody? Because we must remember our ancestors. We are what we are due to them. Some legends have brought dialysis where it is today, and dialysis is our bread and butter. I'm happy somebody thought of doing a dialysis case. Otherwise, you're already talking about glomerular diseases and all. Who's called father of dialysis? Anybody? No, it's not William Kolff. William Kolff is a very, very important man. I'm happy you have heard of him.
So Thomas Graham, sir.
Very good. Thomas Graham. Who was Thomas Graham? He was a Scotsman. He just gave a lecture, and the beauty of this man is he told us the difference about diffusion, dialysis, ultrafiltration in 1850 or 1860, I think, in an annual lecture to Royal Society of England. At that time, he laid out the concepts of diffusion, ultrafiltration. That's why he's called father of dialysis. He did not manufacture anything. Who gave the first dialysis?
William Kolff.
Successfully and unsuccessfully?
Sir, Fick.
William Haas was a German nephrologist or physician, whatever you call. In late 1920s, he gave dialysis in AKI, ARF as it was called, to about 4 or 5 patients, but they did not survive. But the first successful dialysis was given by Wilhelm Kolff. Haas was unsuccessful, Kolff was successful. He was a Dutch scientist and he developed this. And then the Kolff machine went to, I think, United States, to Seattle. And there they did a lot of modifications and exported it all over the world. So William Kolff, Haas, they are very important names for us. And one very important name, what is the innovator of fistula? Simono. Okay. You see, in 1962-63, he created the Simono fistula, and Belding Scribner created the shunt, Scribner shunt. That was the first thing.
Yes.
Belding Scribner was a legend at Seattle, and he created this shunt. But the problem with shunt is, people like us, we have made hundreds of shunt in our lifetime, but then you have to close the distal end of the artery.
Yes.
That's why it's not so popular. But since you are from Gangaram, I'm sure your teachers will tell you there. I've learned my shunt from Dr. Rana himself. So you make a shunt, and on top of this, we used to convert it into artery because the vein would be very thick. Sorry, into fistula. Correct.
Fistula.
But shunt was created by Scribner, but that was not very popular. But then eventually, Simono fistula is still running strong. In 1965, it was first reported. So 35 and 21. So these are kind of the innovations which we need. I think that's all from my side.
Yeah, thank you, sir. I'll also wind up.
Okay, you did a good job, Abhishek. Your presentation was good, sharp, but then hemodialysis is an endless subject. It is basically 1/3 of nephrology. So, good night to all the listeners, and Abhishek, great job. Thank you.
Yeah.
Thank you, Steadfast, Puneet.
Thank you, sir. Thank you so much. Thank you for your valuable
Good,
time.
good, Abhishek. Well done. Bye-bye.
Thank you,
Good
sir.
job. Well done.
Thank you, sir. Thank you, sir. Thank you.
चलो खाना खाएं क्या